So, well, that's obvious. That's what we're going to talk about for a bit of time. Seems quite specific, but I hope we'll explain like why that's important if we're working with people in different aspects of mental health services or whatever we want to call it. It's quite a unique medication and fits in a unique category, and because of that, it's useful for us potentially to like know a bit about it, and that's like really what we're like going to try to do today. Like some people might have seen me talk about these things before. If you've, yeah, maybe I'm a bit boring. But these are just some like press information about clozapine. So the top two from a couple of years ago, but like there's more recent things from the Times and from the Sun. Let's bring some balance there. Yeah, you can see pretty shocking stuff, like talking about it being the most dangerous drug, like causing deaths. On the right hand side there, yeah, danger pills. Pretty shocking, I think. Definitely provoking anxiety, we might say, like if we were asking, talking to someone about maybe taking clozapine or they already take it. And that at the bottom is just the statement of return. So like the response to these things from the Royal College of Psychiatrists. And I think hopefully we'll talk about this over the next bit of time. I certainly have and still do spend loads of time talking to people about these things. Like people ask me like, oh, I've read this, in the news, and is this a good idea? Is it harmful for me? And obviously they're totally reasonable things to ask. And so part of today, I guess I hope that we can, like with everything, and I hope you share this kind of outlook, is that we're surrounded by information about loads of stuff, aren't we? And like a lot of it isn't that great, the quality of information. And I'm hoping that I can give you some information that means that we can promote people to have choice, but in a more or like a better informed way. I guess that's like probably what I'm aiming to do. I was just going to ask, has anyone ever seen these, or has anyone ever asked people about, like, thought about it?
Chris, you know me well, obviously. You did a talk like this some years ago for me. And I really wanted to hear it again, partially because I'm doing my nurse prescribing course.
Yeah, sure.
But it was really, really helpful. So I think if people can get quite a lot out of it. But I think it's probably similar. Is it a similar presentation?
Yeah. Some. I mean, some things change, some things don't. But there is some similarity. Yeah.
Thank
you.
I
won't hold it against you, Lynn, or be offended if you don't want to stay for it. But
no, I'm staying for the whole thing. I've got to do a student log.
Right. Okay.
Sorry, you're stuck with me.
Yeah. Of course. Yeah. These like I said, I mean, these depressed things here haven't changed, but they continue to be present in media like all the time, and people continue to ask me about like or say to me, clozapine is dangerous, I like don't want to take that. And I guess when people ask us that, it's good to be able to think, okay, so what is the best information that we know? So I think it's a good place to start, and hopefully we will decide whether we agree with the press releases here. And that's what I was going to ask. So a bit of background, quick, not like sometimes it's useful to give some context. So clozapine's a medication, an antipsychotic medication. It's old. It was first made in the 50s, but it was actually removed from use internationally across the world because in the 70s it was shown to be linked to this problem where it affects a person's immune system, and it so significantly affected people's immune system, so basically reduced it to zero, that people died of infection because they had no means to fight off infection. And because of that, there was this number of people observed in Finland to have this reaction, and it was removed. I guess people sometimes draw a similarity to thalidomide, which was used for nausea and vomiting in pregnancy, and people probably know it was then linked to malformations like deformities in the babies, and so it was withdrawn from use. It's a similar, sometimes these vigilance things happen, and the reaction is seen to be so significant from a drug that actually it's not to be used. But in a kind of interesting trajectory, there was this piece of work done on the right hand side. The details aren't important, but basically there was a theory that clozapine was something different to other antipsychotic medications, like say olanzapine or risperidone or something like that. And the theory was tested, and in this one study in 1988, and when it was compared to other medications, it was shown to work better. And we'll come on to that. And what why this is interesting and gives us context is that it was then reauthorized. It's called the drug license, so approval for a drug to be used in a country and in the UK and internationally for this specific thing called treatment resistant schizophrenia. That's kind of important because it's the only medication in the world that has this specific use. And so I guess that gives us context in, okay, so who are the people that might take it and why might they take it? I'll come on to that. Again, this is not, the detail isn't important, but I just wanted to bring that context a little bit further. What does that mean? So it basically means when someone has tried two antipsychotic medications, two different ones, for a period of time, and they are definitely taking it, and then their psychosis doesn't, I guess, to an adequate level, doesn't seem to benefit from these medications. So maybe I try a period of olanzapine for a few months and then say haloperidol, and it doesn't seem to help. And the theory, I guess, people often ask is, what does that mean? Well, it's quite probable, and there is definitely not just my theory, but lots of kind of information and research about it, that schizophrenia is a very broad kind of syndrome, illness, disease, whatever we call it. I like the word syndrome because it kind of captures a group of maybe things that are happening. And there's probably different types of schizophrenia, and different medications work in different ways, these antipsychotic medications. But I think a really key part of that here is that clozapine doesn't really affect a chemical in our brain called dopamine, whereas almost all the other antipsychotic medications affect dopamine. So it works in a different way. And it might be, and there is some information to suggest this is true, that's these different types of schizophrenia. And maybe, why would someone's psychosis get better with a medication that affects dopamine if their psychosis has nothing to do with dopamine in their brain? So, and then maybe clozapine, which affects chemicals like glutamate, works better. So there's kind of this specific group within schizophrenia. And I bring that question to us here. What percentage or what estimate, what do we think about the number of people that have schizophrenia that have this different type of schizophrenia, so TRS or treatment resistant schizophrenia? Any thoughts? Please chip in if you feel able. And I'm talking might say 10%, 20%, 50%, 90%. Any thoughts?
I'm going to go with 30%.
Thanks, Lynn. Anyone going to agree, disagree, anything else?
20%. I'll say 20.
Thanks. I can't see who that was, but cheers. Yeah. Anything else?
To let you know, I'm diagnosed with schizophrenia. I'm schizophrenic. I've been in secure hospitals, and I've come across one of my best friends is on clozapine, and I've seen the effects.
Okay.
People in hospital on clozapine, and to be quite honest with you, I'm listening to this because I don't really agree with the tablet, the drug, just put in the picture. But I'll listen to what you say because I'm interested to hear what you say. And I won't butt in. I'm just saying my point.
No, thanks. It's Paul, right? I think
that's correct. Yeah.
Right. Thanks, Paul. Yeah. No. That's really. I mean, yeah. And I hope I'm happy to be challenged on any of the points that I make. And yeah. No. Thanks for listening. And if you do have anything to say, please chip in again. I think I've got a hand up from Simon.
I would go with 40%.
Okay. Yeah. So we've got a range of things there. 20, 30, 40%, some maybe even some like reticence over like what does this even mean from Paul, which I think is like a healthy like thing to think about. And based on like current information, it's like the current estimate. So Lynn was right, about 30%. And I guess maybe it was a guess, but maybe not. Maybe Lynn knew this. It was a guess.
It was a guess, I promise. Just a guess. Just wanted to start off the bidding.
Yeah, thanks, Lynn. Yeah, I guess I hope people kind of agree, or at least appreciate that that's not an insignificant amount of people, like 30% of people. And current estimates about 1% of like population. I'll come to you in a minute, Matthew. A few more hands. Yeah, great. Let's go for it. So I think Matthew, you're first.
Hi. When you say treatment resistant, what exactly are we meaning by that? I mean, because from my experience, I've worked with people with psychosis. From my perception, a lot of them still experienced a lot of what are termed voices and hallucinations and whatever, but they seem to be less bothered about it rather than it sort of reducing symptoms.
Yeah. I think the formal definition, I guess, is there on the slide, where I guess someone has tried 2 other antipsychotic medications and themselves and the people around them have felt that they haven't been helpful. But I think the point that you make is a good one, that like how we define like benefit or like response or whatever we want to call it is tricky. Like none of the medications, or not everyone certainly, like will experience, in my experience, like that symptoms will go away, but like the subtle changes that often happen when people, I guess, feel like they're getting an adequate or a satisfactory response are like, as you described, maybe things become more manageable, maybe they become less important. Those are things I'm sure that people here also have experience of, that people will often share. So that's the formal definition, but obviously with real people like we're talking about that we help, it's obviously a bit more nuanced. But I hope that kind of answers like what you're asking.
Yeah, because I mean, sort of some people I've worked with have wanted to take more Clozapine, some wanted to get off it entirely. So obviously it's a very person-specific experience.
Yeah, absolutely. And I guess it comes back to us that when we're supporting people to know, maybe I can put this to us all, to know these things, like the formal things, and then be able to support and apply them to real people that are like much more nuanced than that, aren't they? So I think it's good to like have this information, and then we can see how that applies to people. Sorry, there's another hand from Emily.
Sorry, silly question. So did you say that it works differently to other medications? Because does it still reduce or limit dopamine activity, or how does it work exactly?
No, that's not a silly question, Emily. I probably just didn't explain well enough. Yeah, it does work. We do think it works differently. The majority of antipsychotic medication work to I'm hesitating because they don't just like limit the effect of dopamine, but they alter the effect of dopamine in different parts of the brain. Clozapine doesn't really do that, and mainly works by affecting another chemical transmitter in the brain called glutamate, and again like impacting the work of that chemical in the brain. So yeah, it works differently, and the current thought is that might be explained why that works better in some people, because the source, the chemical source contribution to their symptoms is the cause is different, if that makes sense. I hope that answers your question a bit better. Yeah. But I say I'm a bit vague with these things because some of the understanding is still being worked on, like we're not 100% sure. But I guess what we absolutely know with more surety is that lots of people take antipsychotics and they don't, that third of people don't seem to it doesn't seem to do anything. And some of those people, when they take clozapine, it works a bit better. And that seems to be quite proven. Paul, I think you were first.
Yeah, just to say about clozapine, I was in the hospital. I'm not going to keep going over about it. A secure hospital, and I was in there with a couple of lads that were on clozapine, and to watch them suffer, to be quite honest. And basically, they said to me, their understanding was it was the last resort or problem because they were psychotic, and that's all they could use to deal with them. They'd already tried. What you said, I agree with what you said. They used other medication, and but the side effects, and I still see it today. My friend, he's still on clozapine, and I see how he suffers, and it's made him obese. He's put on so much weight. Yeah. The sleeping pattern is totally changed. Sometimes he'll go to bed at 11 o'clock at night and won't get up till 3 o'clock the next afternoon. And it's not his fault. It's the medication, basically. I've seen people suffer with it. That's why I suppose I'm a bit skeptical about this.
Yeah. Well, and thanks very much for those insights. And I think I also know people who have those difficulties. And I guess it's, what am I trying to say? It's not simple. I guess I'm trying to give information around context, and clearly we're here because supporting people and our experience is much more complicated than that. But I think I still hold the view that a bare minimum is that we should at least know the context and the source of information. And I'll come on to things about side effects and difficulties too, because maybe then we're better able to help people take clozapine in a better way, for example. But hopefully I can kind of talk a bit more about that in the next couple of slides. Paul, I assume you don't have anything else right now, is that right? Yeah, cool. I think that then means that Simon's got a question.
Yeah, Chris, you mentioned about the side effects, and I'm probably going to jump ahead here a bit, but I'm quite interested in the clinical side of that. So maybe, the managing the risks of low white blood cell count seems to interest me, because side effects are normally caused by the secondary effect. Also measuring the blood tests, regular blood tests, and monitoring the severities of it. So sometimes I think these go unchecked. I'm not a psychiatrist in any shape or form, but sometimes I think there is this restriction of access to monitoring, and mandatory monitoring, maybe. I don't know if that's anyone's experience, but sometimes, we put up with the symptoms because we think that's part of the side effect we should put up with. But in reality, it can be potentially fatal. So that's my thinking.
Yeah. Simon, no, I think there's good thoughts, and I will definitely, I'm not dismissing it at all. I'll come on to some things around blood monitoring, which hopefully will be helpful and interesting and kind of answer those points. Lynn?
I just wanted to say, it was my experience that many years, we're talking probably 2 or 3 decades ago, I worked with a young man who was in his early 20s, and he was diagnosed with schizophrenia 5 years previously. And I don't know how many medications he tried up to that point, but he was started on Clozaril as an inpatient, and few months after he started it, he basically said to the whole nursing team that he felt as though most of the last 5 years of his life were missing from his memory. He didn't remember it, and he felt like that made him feel tremendous sadness, because it's like, I don't really even know where I've been, what I've been doing for the last 5 years. But he felt suddenly like he'd got his life back, like he'd got his mind back. I mean, that was a long time ago, and it's only one example. But I've certainly come across people in the community that are able to work, that have schizophrenia, that are on clozaril, that are able to work on it. And I don't think you come across that quite as often with other antipsychotics, but maybe I'm wrong.
No, thanks, Lynn. I think all of these, but you know, we're in some ways, aren't we? We're comparing what we like information that's given to us, like research, like national information, guidance, etc., with our personal experience, which are like equally as valid. So I think we should bring those things together, and it's really great to hear. Yeah, it's good. Like, I hope people feel able to share these things, like Lynn has, like Paul has, because they're like really important. And I guess I keep coming back to, but I hope I'm okay to say, I certainly feel like it's my job to be able to take this information and like help apply that to people individually, and whatever works best for them. Yeah, so thanks a lot. That was really helpful discussion, I think. So we've got a bit like kind of backtrack. We've talked about like what clozapine is a little bit, like why it might be a bit different. We've talked about like when it might be used, and like that proportion of people that might have this different type of schizophrenia. And so just giving like meds after meds after meds that aren't like are working the same might not help. And so then that's where clozapine might come in. And then I'm just going to come on to a little bit around it's like comparing it to other ones. Lynn touched on it, then Paul's touched on it. We've got a bit about, then just we'll come on to some of the side effect discussion, like Simon mentioned about blood monitoring, but I want to bring in some other things. Yeah, so that's kind of where we're going. So this, I kind of bring it in. The detail isn't that important, but I just want to highlight that this is like why I'm saying some of these things, or at least some of the why, is that these are like, and please don't worry about kind of the detail, but basically these are like two different like pieces of research with thousands of people, looking at thousands of people who have schizophrenia. And it's comparing on the left-hand side of each, there are different types of drugs, different antipsychotic medications. And the further left, basically, the better the medications. And I hope you can see that, like, and this is proven over and over again, that when we compare antipsychotic medications together for schizophrenia, that clozapine comes out the most effective every time. You can see it's at the top, and that's furthest left. And that's like looking at like whether it helps people like feel better, like have improvement in symptoms, and then on the right hand side whether it helps prevent those symptoms from returning. So I think this is like, again, some of the context why I'm like talking about it. And sorry about some of the language here I'll explain, but this is like a bit of description there. So I'll just focus on two things. The top one, so because maybe people ask me this, is that people think, well, you've just showed those slides, clozapine might be better than the other medications. Why doesn't everyone try it? But there seems to be, and I'll go back to this different type of schizophrenia, that clozapine doesn't work best for everyone who experiences or has schizophrenia. It seems to only work better in that different group, that third. And then I want to go to the bottom of the slide there, and that despite, and we're not dismissing, the challenges around side effects and experience, that a person on clozapine who has schizophrenia lives longer, has a longer life expectancy than people who take other antipsychotic medications by about 2 or 3 years, which we all might think, well, that's not that long. But in medical treatment, that is a huge advancement in years. That's more than like blood pressure tablets. It's more than like statins, things that we might like see as quite normal. So despite all the challenges, and which we're going to go through some, you know, overall, the positive effects are significant. And there are some other things there about like that it improves symptoms, different types, quality of life. Like when we talk about people having jobs, relationships, people on clozapine are more likely to have those things overall. Yeah, so they're like some of the reasons why it's important to think about. Just talk a bit about like the work I do. So a lot of the work I'm doing at the moment is, I guess, like this, is trying to improve how we use clozapine and how we allow people the opportunity to try it if they think it'd be helpful, if I think it'd be helpful, we think it'd be helpful, and also they think it'd be helpful in different ways. So improve the way we use it, basically. And this is a bit about the context that currently in that group of people we talked about, that third of people with schizophrenia that probably have something different, only a third of them in the UK are offered clozapine at the moment. Not like taking it before, but they've never even offered the chance to try it. So I think based on the benefits, and I know there's been some really good points about the safety issues we need to be, which is really important, but we're not even giving people the opportunity to try it who might benefit. So I think that's important because we should be at least offering people to try it. And we're going to come on to that a bit more. I think there's a question. Yeah, Paul, come in, please.
Yeah, just to say, I will tell you, I was in Langdon Hospital for 3 years on a secure ward. And okay. I know for a fact, if you wasn't well and you didn't take your medication, it was forced on you. You had no say in it. And I don't know if that's still the case, but sometimes you were given clozapine, where even if you didn't agree with it, the psychiatrist made the decision and the injection was administered or whatever tablets taken.
Okay. And yeah, I think, Paul, that is an experience of some people. Please, it's obviously sensitive, like that's not an easy thing to talk about or to have done to you. That's not ever happened to me, so I guess I'm cautious in kind of bringing a big opinion on it. I have definitely been involved in those situations. I guess, fortunately, and this is my opinion, that is not the experience of everyone. Like, as in, I think it's good, isn't it, that we, what am I trying to say? Part of the work that I'm trying to do is to give opportunity for persons to be involved in choice around their medication at a time maybe when it's easier for them to make choice. That might be when they're at home, not in hospital, and I'll come on to that. And so I think part of using a treatment, whatever it is, better is involving the person in the decision. I hope that's my opinion. And so I guess avoiding those times when those choices and decisions are taken away from people. I hope you agree. And so I think by us being more informed and like maybe thinking about, say, clozapine, we maybe can, I think we can support people better to like have even discussion about it. What does it mean? And we're like helping people like make choice. I guess it's like an aim of what we're doing, because my opinion is that isn't a good thing to be forcing people to do anything, never mind like what medication they take. And I guess, and just to be clear, some of these are my opinion alone, is that then it's not sustainable. Like if we force someone to do something, we might be able to do that for a short time, but I hope we all agree that the person is going to do what they want in the long run. I certainly, if someone forces me to do something, I'm going to definitely try not to do it. And but I guess that's a tricky thing. And I'm just going to repeat myself. I know is that a lot of that was my views. Liv?
I just wanted to ask, Chris, I don't know whether you know, what kind of percentage of people might be on Clozaril that are on a community treatment order? I don't think I've come across it very often. I know some people are on other depots that are on community treatment orders, but I'm not sure about Clozaril.
That's a good question. And then I hope you don't mind with a bit of explanation. Like some people might know, I'm sure lots of people know what community treatment order is. So like a part
I'm happy to give an explanation if you want me to.
No, it's all right. I mean, part of the Mental Health Act where people are in the community, and it kind of, in some ways it enforces or it like restricts them taking medication in some ways, a bit like what Paul kind of was suggesting, but not in hospital, in the community. And I think that's important, isn't it? So we're talking about what proportion of people who take Clozapine take it by choice, I guess is a useful way to think about it. I actually don't know like the exact numbers. What I do know is about 500 people in Devon take Clozapine at the moment. And there's a lot less people on community treatment orders than 500. So I think in my personal experience, which is, I know is limited in some ways, is that only a tiny proportion of people are forced by law, one might say, to take Clozapine. The majority of people absolutely are, ultimately at home, in whatever home they have, like taking it by choice, which is obviously really good. But coming back to the slide, and I've kind of gone on a bit of a tangent, is that the point I was trying to make is that there are people who could benefit potentially from Clozapine that we're not even given the opportunity to try or even discuss it. And I think that's like an area where we're trying to change it. Okay, so lots of good discussion there, thanks. And the next section that I'm coming on to, which has been hinted at a lot, some good, and I'm hoping there'll be some experience to share again, is around like the side effects of medication, of Clozapine. Bit of a summary. So it's the only antipsychotic that seems to be better than the others when we compare it and remember those graphs, but there's quite like a strict requirements around its monitoring, and that's because of these potentially serious side effects. I've intentionally included there, I guess, the kind of medical terminology, because that's often what's like in piece written down, what we have to like maybe people ask us about. So agranulocytosis, that's like the word for when someone's immune system is completely suppressed, so their white blood cells are damaged or not working. Myocarditis, that's where our heart is inflamed. Low blood pressure, hypotension. Constipation, we probably know what that means, know what that means, not being able to poo. Tiredness, lots of dribble. People often talk about that, especially at the night time. People have already talked about gaining weight, and rarely sometimes people have fits. So complicated, loads of side effects. Like, why would I take this? And I guess we talked about why we might take it, and we need to, I put it to us, we need to be able to think about these side effects to help someone take it, hopefully experience them as little as possible. But if they are experiencing them, or they might, we need to make it safe. So I'm going to talk, I've picked out a few key ones that I think probably lots of people have experience of, and that I think are really important to know about in us helping people to think about Clozapine, but also if they do take it, to take it in as good way as possible. So I start with blood testing. I think it was Simon that mentioned about it initially, but it's a really important part of it because it's a strange one in some ways. Because remember where I talked about the context, it was used for 20 years, and then it was seen that people were dying because it was damaging their immune system, and so they were getting infections and not able to survive. So it was reintroduced, but a person has to have monitoring of blood tests on a regular basis, and a minimum of every month at the moment. to check that their immune system is working and the clozapine isn't having this problem. Emily?
Does this mean that people living with HIV aren't able to take this medication?
That's a really good question. No one has asked me that ever before. Sorry, I only laugh because it's such a good question. No, that's not true. It's a good question, because I guess my interpretation of it is that HIV can suppress someone's immune system, and that's like really obviously that's what causes AIDS. And obviously we wouldn't want two things to be doing it at the same time. But if someone is treated for HIV, which now, and probably people know, like, can be very effective with medication, so like, hold the virus and it doesn't progress to things like AIDS, then no, like, it might be that it's slightly more complicated, that we have to like do some extra things, but no, not necessarily. Someone could potentially take clozapine and have HIV. I think that has only happened to me once in 15 years. I can't remember another, but yeah, I guess more commonly in a similar thing is that when people unfortunately may have a type of cancer, often the treatment for cancer is chemotherapy. People have heard of it, and often the chemotherapy can suppress, like, damage immune system. And so it's at those times when sometimes we have to do extra tests, like extra blood tests, to make sure that that combination of the clozapine and the chemotherapy isn't like causing a problem with the person's immune system that's harmful. So there are times when, yeah, we're doing things that are double harm, but often it can be done safely, basically. So coming back to that, it means that, and we're probably aware of it, it means that if someone misses or doesn't have blood tests, doesn't have their monthly blood test, they can't, the pharmacy, they can't be given clozapine. It's like it comes one with the other one. And it means people are like registered with these monitoring services that are run by the hospitals. Here in Exeter, for example, it's at the RDUH. And there's a very strict process where the person does their blood test in like, say, the first week of the month. The blood test shows that their immune system is working absolutely fine. Their white cells are normal, and so then they can carry on taking Clozaril. If that doesn't happen, then they can't carry on taking Clozaril. Like, the pharmacy is literally, it's illegal for the pharmacy to give out the Clozaril. So that's often why we talk about blood testing, and there's a very strict criteria around it. Yeah, does anyone have any questions about that?
I'm just interested in what are the side effects when you come off of this medication. Say you get put onto another medication, because I know myself, being in hospital, you've tried on quite a few medications, which is understandable, and I accept that. But what would actually be the side? I don't know this myself personally, because the people I know are still on clozapine. What would be the side effects if you come off of clozapine and went onto other medication, or no medication whatsoever?
It's a good question. Well, the only reason I hesitate, I mean, maybe there's no good time to talk. I was going to say, can we talk about that in a minute? But no problem. I think it's a really good question, and it's a question lots of people ask, isn't it? One of the challenges with, I mean, when we're talking about schizophrenia at the moment, but we could talk about loads of illnesses, couldn't we, where we don't necessarily have a cure, like diabetes. We can't replace someone's pancreas at the moment. So if someone has diabetes, they have to inject insulin every day for their whole life. There isn't a replacement at the moment. And I guess in the same way that potentially someone with schizophrenia, the medication isn't correcting permanent correction of maybe what's happening in their brain. And so no matter what antipsychotic medication we're talking about, is that for almost everyone, in stopping antipsychotic medication, there is a chance that their experiences, psychosis, whatever we choose to call it, will return at some point. One of the difficulties with clozapine is that happens quite quickly. the chance of relapse or return of symptoms, whatever we call it, is very high on stopping it. And I think, Paul, just to answer your question, I guess, and this is a discussion I have with people a lot, is that if someone's tried medication before and it's not been helpful, well, then to go back from clozapine to one of those medications, in some ways, to be blunt, like, what's the point? That doesn't mean that we sometimes don't do it, but I guess repeating something that we've shown not to work is probably not always the best idea, I guess. I hope that kind of answers your question. Yeah, we'll carry on, because I've just got a bit more about the blood tests here that I thought might be useful. You can see, sorry, that's a bit like a lot of words there, but on the slide there, I just wanted to kind of highlight that the blood test schedule when someone starts clozapine runs like this. So it's every week for that 18 weeks of someone taking clozapine. Then for the rest of that year, it's every 2 weeks. And then after someone's taken clozapine for a year, it's every 4 weeks or monthly. And that's because the effect on someone's immune system is highest at the start. So we want to check it more. And then that reduces with time. And the bottom bit there is this thing that the reason I put it in is because people talk about this quite a lot. It's like, oh, I've come for my blood test and it's green, in inverted commas. And all that means is those numbers there are just the measurements of the white blood cells. So if it's green, it just means that the white blood cells are normal and that the immune system is working fine. And if it goes to amber, it means that the immune system is working a bit less. And then if it goes to red, it's working even less. And so it's getting more dangerous. And so we use that traffic light system to be like, okay, so the person's immune system isn't being affected by clozapine. Great. That means they're safe to carry on. So it just is, I guess, a kind of way that we talk about it. And it's based on how well the person's immune system is working. Does anyone have any questions? Great.
Yeah. I just wanted to ask if a user of clozapine if they stop taking a medication and we have to retitrate again, do we have to follow through this process again of the monitoring system like this blood test?
Yeah, that's a good question. Sorry, I don't know your name.
Winner. My name is Winner.
Winner. Nice to meet you. Thanks for your question. It's a good one. And it kind of comes on to this point here, which is a bit, I think you mentioned about if someone stops clozapine. I will definitely answer what you're asking, but I'll combine it with this point if that's all right. This was a real scenario that I was involved in. And I say resident, we say person, whoever we're working with. It happened to be someone I was working with in supported accommodation here in Exeter. They went to a music festival. They took clozapine normally, and they took 100 milligrams twice a day, morning and evening. But they came to clinic and they can't remember when they last took it. They were partying, they were having a fun time, they had a really good time at the music festival, and they missed some doses. Does anyone have any idea what they might do, what they might suggest here? Can the person go back to taking their normal dose of clozapine? Is there anything? Do we change the blood test? Anything like that? Matthew?
I believe if in a 48-hour period you've missed all your doses, you have to be retitrated, as gentlemen sort of talking about just now.
Yeah. Thank you. Really good. Yeah. Couldn't have said it clearer, I don't think. And it links to the point Winner made, is that we have this rule, and I call it a rule because it is a rule really. If a person misses over 2 consecutive days, over 48 hours of clozapine, basically, because clozapine works in a person's body for a really short time, it means that they lose tolerance to the side effects that we're talking about. And if they were to go back to their normal dose, like this person here, so maybe they've missed 3 days, maybe 4 days, the clozapine has almost left their body. It's almost all gone. And it means that it's dangerous to restart the normal dose. And so we talk about a retitration, we talk about reinitiation. All that means is that we start at a lower dose, and we increase the dose over maybe a week or whatever is appropriate back to the normal dose. But the thing to remember really, and I'll put it here, and I'll explain some of that information, is that bottom bullet point on the left. If we miss over 48 hours, we can't go back to the normal dose. And that's because of this loss of tolerance. And the main loss of tolerance is back to this effect that clozapine has on someone's heart. So it makes your heart beat faster. It makes someone's blood pressure, so that hypertension, that just means low blood pressure, tachycardia, fast heartbeat. And those two things combined can sometimes, for some people, mean inflammation, so swelling of the heart, and that's that myocarditis. And that's dangerous. I hope you kind of appreciate. So, and that can reoccur, so happen again, if that person's like has this loss of tolerance. And so when we start clozapine, it starts at a really low dose and increases over a period of time, usually 3 or 4 weeks. And that's to allow the person's heart to get used to it, basically. And again, if we restart clozapine, because there's been this period off, we kind of have to go through that same process. And it's to let the person's heart kind of get used to it, basically. Yeah, and I guess I'll come on to like what we do to support people through this process and what my team does. But I don't want to lose kind of the importance of that 40-hour window, because that can obviously happen to anyone we work with. And the question that Winner asked around how does that affect the blood monitoring? Well, interestingly, it doesn't affect the blood monitoring for the majority of people. So the tolerance that we lose to the clozapine in terms of someone's heart is not the same as that we have to someone's immune system. This is interesting. There's a difference. So the effect on someone's immune system is the only side effect of clozapine that isn't affected by the person's dose. And so if someone is on 100 milligrams, their effect on the immune system is potentially the same as if someone was on 800 milligrams. Every other side effect that we're going to talk about is affected by the dose. So if someone misses some clozapine and they have to titrate again, they have to go back up on it because of the effect on their heart, it doesn't mean that they affects it. Sorry for that. I hope that's as clear as possible, is that the effect on their blood cells, their immune system is separate. Does that answer your question? Yeah, and Lynn, you're going to come in on that?
Just wanted to try and firm that up in my head. So
sure.
If somebody doesn't take it for 48 hours, they have to start it again from a really low dose.
Yes.
But they don't have to go back to having weekly blood tests or fortnightly blood tests. They can just have monthly blood tests still if they've been having it for over a year. Right,
yes,
okay,
exactly.
Thank you.
And that's because the effect on the immune system is independent of like them. That you know, once they've got through that year, they've kind of proven in some ways that person doesn't have that reaction. And in somewhat confusing, a person doesn't suddenly develop that reaction to their immune system. If they're gonna have it, they're gonna have it in that first few months of taking clozapine. And if they don't have it, then they're never gonna have it, basically. It's like an allergy, basically, to clozapine. But the 48-hour thing is really important for all the other things we're going to talk about, and we're going to talk about constipation in a second. It's also important for that. So this happens, you know, we've probably all got experience of this, like someone misses a few days, like I talked about this scenario, people doing stuff, busy lives, kind of mishaps or whatever we want to call it, like it can happen. And I think it's just important for us to know that we need to be aware of it. Any more questions on that? And did that answer your question, Winner? Yeah, perfect, great.
Thank you very much. Yeah.
No problem. So I talked a bit. These are like some, you know, we've talked a bit about the effect on the immune system. Really important effects on the person's heart, especially when they first start clozapine, and it means that we've got to start it slow, and we have to do that again if someone misses it. Then we're going to talk about maybe the most important side effect of clozapine, which is constipation. And again, bear with the detail, but I really wanted to show this picture because I thought it highlights it really well. So this is like a test, like a piece of research where we compare people who are taking clozapine to people who aren't. They have a special drink that has these like beads in it, and then we look to how long it takes for the person, these like beads that show up on x-rays, how long it takes them to pass through the person's body. The way that we're measuring how quickly someone's bowel is working, how quickly they're like digesting basically, and is clozapine affecting that? So the transit time, so that's how long it takes from the swallowing for someone to have a poo. On normal or average is 20 hours. In someone that takes clozapine, what do we think average is? If like someone not taking clozapine is 20, what do you think it is for someone taking clozapine? Any ideas? Please chip in. Double, so 40 hours. Yeah. Anyone else? Paul?
3 days.
3 days, yeah.
And maybe longer. My friend, that's one of the things you should say about this. He really struggles.
Yeah.
Going to the toilet. He's ended up in hospital a couple of times where they've had to monitor him because of their clozapine being in his system. Anyway.
No. Thanks, Paul. And I think that's really important, and why I talk about it, because it's very dangerous. So, thanks for sharing. Anyone else got any ideas? Emily?
Is that part of the reason people have said it can affect their weight?
No.
That's a good question. Clozapine can affect people's weight by them being really constipated, but the majority effects on someone's weight are more related to the way that it can stimulate someone's appetite and make them eat more carbohydrate. Yeah. But no, it's a good point. And sometimes we use, or it can be, that weight to see if someone's opening their bowels, like it is that significant. So I guess our answer is about 100 hours. So Paul's 3 days, isn't like far off, like so it's 5 times longer. So that means that someone's like bowel, someone's like intestines are working so much slower, and they're slowed down. So when around our like intestine, when we in our body, we have muscles that like move, like that work to move things through our body. And clozapine and other medications, like people might know that, like say painkillers like codeine, stop those muscles working as well. So they slow the effect of our intestine, and that slowing down is constipation, could cause constipation, and it slows it down so much, like 5 times slower. And so that's really important, because when someone's constipated, you might think, well, they're constipated, it's uncomfortable, they're bloated. Yeah, that's really unpleasant. But also it can mean that the wall of their intestine gets holes in. It's called perforation, and that's really dangerous in terms of infection. It can mean the bowel swells, and that can put pressure on their body. Sometimes people can have a heart attack as a result of that. So this happens to, constipation happens to almost everyone who takes clozapine. And because it's and I've written there that people often, when I ask people, or when people are asked, it because it's something that happens all the time or over a long time, it feels like normal. So people often think, no, I'm not constipated, because I guess it's just a normal feeling. And I know this is like morbid in some ways, but I put that at the bottom, that 5 times more people die who take clozapine related to constipation than related to their immune system effects that we've been talking about. So this is really important. And the obvious question is, then what do we do? What do we do? I think it's awareness that this happens, and the ways like to help, or to like for someone to help themselves are relatively straightforward, the same as everyone. So drinking good fluids, trying to have fiber, and taking laxatives. It's not complicated, but it is something that is important for everyone who takes clozapine. And I know I'm kind of I'm stressing importance on it, but I think it is really important. And so I guess in people that you may be supporting that take clozapine, this is something to really be aware of. And if people are having difficulties like new constipation or worse, it's really important that they get help around it. I hope that all makes sense. Really important thing for us to be aware of. Does anyone have any questions or want to share anything else? No? Okay. So they're like some really key areas that I wanted to share in terms of, I guess, if we're supporting people with clozapine, who take clozapine or might take it, they're need to know kind of things. We've talked about, kind of go in a summary loop again. We talked about what clozapine was, why it might help, what does it help with, and some really key areas of safety, like that are dangerous potentially, that we need to be kind of supporting people. Yeah.
I just wanted to ask if the dosage level affects the constipation level. So, like, for example, someone who's taking like 800 milligram or 400 milligram twice daily, and someone who's taking 200 milligram twice daily, would they have the same level of constipation? Like,
no, that's a really good question. Maybe to answer it, the more dose for a person, the more likely constipation. So one of the things that we might suggest, or I often do, is that if someone is really constipated, then maybe they're taking some laxatives, but it's still difficult. Then a reduction in dose would be a good, potentially a treatment, because lowering the dose would lower the effect of constipation. Does that answer your question?
Yeah, it answered the question. Do we also have to put into consideration how it affects, if you reduce the dose, like, we also have to consider the impact on their mental state as well?
Yeah, absolutely. And I guess, I think it's important to recognize, I hope you agree, that in that complex, like, balancing of like the benefit of the clozapine versus the side effect, that absolutely, though, the higher the dose, the more likely constipation. So we might then decide, okay, well, actually the person is managing their constipation really well by taking on good fluids and taking laxatives, so I don't need to reduce the dose. But always a consideration, is the dose the right one for the person, should be part of the discussion. But it's a really good question, you're right. And a very difficult thing, like with all these things, we talked about the side effects on someone's heart. We're talking now about the side effects on the person's intestines and constipation. It's often a balance between, and I know Paul's still here, I think. He talked about, people having really difficult times taking clozapine. It's a balance between trying to get the best of it without causing the side effects. And I was like summarizing, we talked about those things, we've talked about this balance. And I think I just wanted to go back to this, is that it's still, despite these really serious things, that clozapine still reduces like mortality in people that have schizophrenia. So the longest life expectancy of people with schizophrenia is those who take clozapine. I think we must keep that in mind, based on that we must consider those serious things, but we must also consider that despite that, if we use it well, if we do the things that we've been talking about, then it helps people live a better and longer life who have schizophrenia. And I think I often bring that up because, and I'm going to go all the way back to the slides that I said at the start, where the press releases, remember that we said clozapine is a death tablet, causes deaths. I hope that I've highlighted that is not true. And I don't always like to be concrete about things, but based on what we know at the moment, that is definitely not true, and actually is the opposite. But I think that doesn't take away from that if we aren't aware of these important things like constipation, like people missing doses, that it can be dangerous and we need to use it well. But if we do that, then it's effective and improves people's lives. Okay. So we've been talking, I think, for about an hour. I've got a few more things to talk about that are really useful, I think, and important in supporting people who take clozapine. So I hope you can see the slides again. Question about smoking. Clozapine? Does anyone have any thoughts? Someone who takes Clozapine was recently accessed to stop smoking service, and they're using patches. Any thoughts? Matthew?
Yeah, I think any potential change in nicotine usage and nicotine levels in the blood always requires some sort of review.
Yeah, thanks. Does anyone have anything they want to add or expand on that? Or disagree?
I will say this about my friend. He's actually stopped smoking, and it's improved so much more. He said is. But I've been told that about my medication as well. I'm on antipsychotic medication. I have a depot injection every 3 weeks. And,
okay.
A few people I'm talking to, so it's not necessarily just Clozapine, to be quite honest with you.
No, I agree. Well, I'll expand on that in a sec. Thanks, Lynn.
Just wanted to ask about, I think somebody had previously told me that it's only cigarettes that need to be taken into account, not vapes, because it's not the nicotine, is it the tar? I don't know.
Yeah, no. I will hopefully answer that. No, that's a good point. Yeah, so it's important, and I'll expand on it around other meds in a sec, but like when someone smokes, it's there. So when you burn the cigarette, these like chemicals, the hydrocarbon chemicals that are produced when it's burned, affect these chemicals, these enzymes they're called, in our livers. And we have these chemicals in the liver that means when we take certain drugs into our body, they break them down. They're like metabolize them. They're called CYP enzymes. And there are different ones for different drugs. Not every drug has a separate one. There's not very many of them, but they obviously break down in different combinations. But the chemical that breaks down Clozapine is also affected by this effect by cigarette smoking. So what that means is that when we smoke, a person smokes, the chemical in the liver works more, so they break down the Clozapine in the body quicker. And so I guess what that means is that, we can work it out, can't we? So if someone starts smoking, then the effect of the Clozapine reduces, so they're breaking it out faster. And if the person stops smoking, then they break it down slower, and the effect of Clozapine increases. So obviously that's important in terms of the Clozapine might work less, or it might work more. So if someone stops smoking, like often now, if someone goes to hospital for whatever reason, and it's a smoke-free area a lot of the time, then the effect of the Clozapine might increase a lot. And that links to a question we had a little while ago around, okay, well, that might mean that the person becomes a lot more constipated because the effect of the Clozapine is increasing. Equally, if that then person leaves hospital, so is discharged, and they might start smoking more, then the benefit or the effect of Clozapine might reduce, and that might work less for the person. So it's really important that any changes in smoking affect the Clozapine level really a lot. And I think linked to what Lynn said is that this is not related to the nicotine. So it's related to the way that the burning of the cigarettes. So if someone vapes, or they take patches or gum, then that doesn't affect it. And I guess the scenario might be that if someone goes from smoking to using a vape or an e-cig, then that is the same as going from smoking to nothing. Important. Lots of people smoke who take Clozapine have schizophrenia, about 70%. And so this is a really important issue. And obviously I hope it's fair to say, like, people often want to try to stop smoking, and that's tricky. So it's important that we have if we have this knowledge. And then I just wanted to finish on what Paul said, that yes, I agree, Paul, that this doesn't just mean Clozaril or clozapine. It can be other meds too. So clozapine, it's really important because the effect is so much, like by half. But other medication like olanzapine, like some depot injections, like Paul mentioned, can also have this effect. So it's just worth being aware of. Yeah. Any thoughts or questions? Okay, great. Paul, did you want to come in there? I saw you. Oh no, you muted. That's fine. And then I guess I just wanted to kind of finish a bit, really wrap it up. That a few kind of logistical things which people are probably really aware of, but just be clear. Clozapine is special in the sense that it can only come from the hospital. So people probably aware that, maybe someone's medication like olanzapine can be prescribed by their GP. To get it from the regular pharmacy like Boots on the high street. But clozapine can't be prescribed by doctors outside of mental health. And so it always comes from the hospital. We've talked a little bit around that initiation thing, so I won't come into that. And I'm just going to come on to this community support in a second. So I'll skip over that for now. If you found this helpful, or you thought this is not helpful and I want to learn something better about clozapine, then I can share the access to a really good, in my opinion, e-learning program. If you think I want to learn a bit more, or maybe in the future, like I kind of was, that was useful and I need to remind myself, I can share some like online learning, and I just I will give that to anyone who wants it. Paul?
Yeah, I'd love that, please, if you could send that.
Yeah, of course. Great, absolutely. What I'll probably do then is I'll just share the access through Tom, so that can go to everyone who's attended. If you want it, you can have it. If you don't, no bother. And it's like there's guidance on how to get the login. It's really straightforward. It's free and everything like that for anyone who wants it.
Thank you.
Yeah, of course. And then I guess a bit of a plug for the work that I'm doing. So I support a team in DPT called Treat. And I said at the start, like working with people who've got significant schizophrenia, more complicated, maybe like want to try or have tried, have not had the chance to try clozapine. And we're doing a specific piece of work where we support people at home to go through that process of gradually increasing clozapine over a number of weeks, instead of having to like go into hospital, and offering people like more choice around how and when they start clozapine. And that's like kind of brought me to speak to you today in some ways, but also like if there's some information there. So if people are working with people who take clozapine or are thinking about it and they think I want some more information or support, then please get in contact. Yeah, I guess to finish my talking, I think we've gone through this. So it's the only drug for that special type of schizophrenia. It's probably the most effective antipsychotic medication we have. We don't offer it to people enough or give people choice, but we do need to know things about it to use it well, to keep it safe and to make it good for people to take. Yeah, I hope that you agree that that's what we've talked about. I'm going to stop sharing. And yeah, I guess I now thought if anyone has any questions or anything else we wanted to talk about, yeah, please. Yeah.
It's Winner. So I just wanted to ask if you're going to share this slide with us as well, the presentation.
Yeah, of course.
Oh,
not a problem. I'll share it through Tom, the same, so that access to the e-learning if people want to learn more, maybe not now, but in the future. And yeah, of course, if people want the things I've shared, not a problem. I'll make that available. Does anyone have anything else they wanted to ask? Matthew, yeah.
Hi. I mean, obviously you're sort of. I'm going to try and be careful in how I say this now. You're enthusiastic about clozapine in certain situations.
Mhm.
Would you say that's a fair?
Yeah, I think that would be fair to say. Yeah, in some ways.
Well, I mean, my point would be that, you know, alongside clozapine, what other interventions tend to be offered? Psychotherapy, other interventions. I mean, I know with medication, it's probably useful for showing improvements on clinical scales in the short term. But I mean, what about long-term treatments like psychotherapies? Where do they sit in this sort of situation?
I think that's a really good question. I guess I would challenge in some ways that short-term life expectancy is not a short-term outcome measure, and neither is like things like how many people are in employment or how many people are in sustained relationships, and all those life things, when measured over like long periods of time, are improved with things like clozapine. So I guess I agree that sometimes we can be overly focused on symptoms, if I can call it that, but I think it's important to recognize that that's not the only benefit that we're talking about. But I agree that like support and treatment is multi-layered, and I guess if we're talking about specifically about psychotherapy, then teams like mine and other teams offer, I guess, the psychotherapies that have been shown to work the best for people that experience psychosis, like CBT for psychosis being an example, and when used in combination with medication are very effective and have been shown to be effective.
Chris, can I just say thank you for this talk? It's absolutely fantastic, mate. Very interesting. I'm still against it, to be quite honest. But what I'm going to say is, like, everyone's different, and everybody needs, and the schizophrenic needs different kind of medications, and if they work for you, then that's good. I mean, I'm quite lucky. My Depa injection, which I've been on 12 years, works really well with me. So, but as somebody who's maybe not so well and needs clozapine, then maybe and it works, then there you go.
Thanks, Paul. And I think we all bring our bias into a situation, don't we? We have our personal experience, which is based on like people maybe we've supported, maybe our own experience. I guess I am not here, although, and Matthew is right, I like bring some enthusiasm because I think that's important. But I guess I'm not here to market clozapine. I'm here to share some information that might be useful if we're talking to people about clozapine and they're asking us questions about it, or they happen to take it. And I think it's important that we help people with the best information that is available at this time. And that changes, and it has to be applied to individuals, doesn't it? And I do that the same as I'm sure you all do that too. So I think in that context, I think it is an effective treatment, but it has to be used well, and that used well is responsibility of maybe us. I hope that like makes sense. But yeah, I agree, Paul. Like, no treatment is the right one for everyone. But I also think, and some of these, my personal views is that if we are going to offer people to try different, and that could be a psychotherapy, it doesn't have to be medication, then we should do it to the best of our ability. Whatever that is. Any other questions? No? Right. Simon?
Yeah, Chris, I'm really new to this kind of, knowledge, and we were asked to sort of come and get an overview, and you've done that brilliantly well. I think for me, with young people that I'm going to be kind of supporting, is if it saves lives, that's the initial. If it saves lives from sort of suicidal thoughts or suicidal awareness, because I'm very sort of big advocate for young people with, suicidal tendencies. And I think that if we can just get over the biasness of it and the stigma of it, and I'm kind of not speaking from an experience, but I'm speaking from a kind of human view. If it saves lives, and that's the kind of mandatory outcome, and I don't believe anybody's life's mandatory, but if it comes out as being above and above average in lives, I think it's a worthwhile efficacy. Does that make sense?
Yeah, thank you. Yeah, I agree, and I think at least by holding that, which I share, by holding that view, we at least go into a situation open-minded that things might be helpful. Yeah. Matthew?
Oh, yeah. Simon did just remind me. I mean, I'm not sure how this applies to the UK, but I mean, off-label uses of clozapine. I have seen some studies done into sort of, I think, personality disorder, bipolar disorder, and substance misuse, which have sort of suggested clozapine could be useful in those areas as well. What's the current status in the UK of off-label use of clozapine?
Thanks, Matthew. It's a good question. And I guess just to explain, and lots of people may understand, but just in case you don't, the terminology, that's when a medication or other kind of treatment is used maybe like slightly outside of what it was originally designed to do or what it's authorized to be for. For example, we talked about clozapine being authorized for that type of schizophrenia, but there is actually sometimes it's tested or tried in maybe in another type of illness like bipolar disorder or, like Matthew said, personality disorder, and it's found maybe sometimes by chance to be helpful. And in the case of clozapine, that has happened in those other illnesses or whatever we want to call them. But the effect is, I guess, to be blunt, the support, I guess, the information, the research that we have to support that use is much, much less. And so the relative numbers of people, I hope you can kind of see the correlation, that take clozapine for other things is tiny, tiny, like less than 1%, which is good in my opinion, because we should be using the things that are proved to be useful. And if we don't have that much proof that it's useful, then we should be careful using it. I hope that kind of makes sense. So yes, they are sometimes used for other things. Yes, clozapine is sometimes used for other things, like Matthew said, but it's a small amount. It doesn't mean that it can't be helpful, but it's just the support for its use is less. I hope that makes sense. Yeah, but it's a really good question, because that happens in lots of medications, therapies, whatever we want to talk about, is that sometimes they're used outside of normal.
It happens on mine as well, because obviously being on a depot for schizophrenia, I have clozapine, not clozapine, Dipixel. And I'm given side effect tablets, Prociclidine, which are actually used for Parkinson's disease.
Yes. Thanks, Paul. Yeah, that's definitely, it's a perfect example. Simon?
Yeah, I just come across a very interesting article. It's called Pub Ed Central Government, and it talks about the gaps, the education gaps. Many child and adolescent psychiatrists feel unskilled in initiating clozapine and have not received formal training. Studies show roughly between 35 to 50% of child and adolescent psychiatrists in the UK have not received formal training on its use. That's so interesting.
Yeah, I know the article. I am that boring. But so a piece of work that we're trying to do in my team is that we initially designed the team to be, which is not that unusual, like for adults, so for over 18s. But what we've done with the work in Devon with the child and adolescent mental health team is that we've decided that we won't make an age cutoff. So, and what has happened, the numbers of people that are in, supported by child and adolescent mental health services with schizophrenia that like need support from specialist teams like mine are small, but we do offer support and training and direct clinical care to the people that need it, in that context, that maybe those teams aren't as experienced, don't have that same skills, so we can offer that as an add-on if people need it, as a way to try to get around those maybe deficits. But I think it's important that we reach and we offer these things that we've been talking about today to whoever needs them, wherever they are. Anything else? Any other questions? We've talked for 2 hours. Well, I've talked at you for 2 hours, so thanks so much for listening. It's been rich and so many good questions, fantastic. It's so much better for me, I hope that's okay to say, when people are asking questions, because then I remember I have to think. But I hope that's been helpful. So what I'll do, I think I've said that I'll share the slides with Tom, and I'll also share the details for login to the e-learning, the national e-learning that we support if people want a bit extra or something in the future. That's free, accessible, etc. And unless anyone's got anything else they want to add or ask me, sorry, Lynn, just 2 seconds. I'll just remind people that those contact details, if people are working with people who take Clozapine or are thinking about it or anything in this regard, please feel free to contact if that you think that more support would be helpful. And those contact details are on the slides. Sorry, Lynn.
I was just wondering if you could put the link to the other training in the chat bar at all, or?
It's a good question. Sorry, I laughed because I don't have it, but I'll find it.
Oh, that's fine.
I just don't have I can't remember how to get the login details for you all, so you can get it for free. So I just need to find that, and I'll share it in the email.
That's fine. The slides that you're going to share with us, have they got references on the?
They do.
Excellent. Thank you very much. Thank you.
All right. Cool. Well, nice to meet everyone. Thanks for listening, and have a good afternoon. Take care.